Well, thank you. And it's warm here. No snow. You have sunlight, or sort of. I appreciate that. I'm actually want to thank you and Cadith for the opportunity to join you and to participate. The North is often forgotten, both in research and in evidence, and on how the health system can be sustainable. And I'm also very honored to share the presentation with two Deputy Minister colleagues who I greatly respect. The NWT relies very heavily on agencies such as Cadith, on other national agencies, and also on the southern jurisdictions, who many of those decisions guide what happens in the territories. I'm going to just highlight a little bit of what we're doing in our reality, and I'm hoping that I shame you in that your evidence in the future makes sure that it has both a northern and an Aboriginal lens, and that you understand the capacity issues and the delivery issues faced by the three territories, and in particular the Northwest Territories, in delivering health service. Your evidence and your research is fabulous, but it doesn't often meet our realities. The North and its health delivery challenges are areas that are not always recognized by research or by the discussion or even referenced. Our data samples are so small that we seldom even show up in all of the Kai-Hai material. So I also have to tell you that the three territories are very unique. Both Canadian governments, the national agencies, and researchers often see the North as the North, and yet we are very distinct, and we need evidence that will speak to the realities of our differences. So I'm going to tell you a little bit about the Northwest Territories in hopes that you can see the challenges and how some of the health technology and evidence and research is just not quite singing to us. We're challenged as well as other jurisdictions by constant demand for more and better service, both by our public and by our providers, and by what everybody reads about is happening in the South. And we do so with an extremely limited small budget. We spent mine before Terry was finished talking this morning. And it's not sustainable. Our system is already changing in an unplanned way because of the change in provider practice. We live with much more solo, independent, rural and remote practice, and yet most providers are now being trained to work in teams. They don't exist where I am. You often have a health center run by 1 or 2 nurses. Sometimes the bandwidth works and we can actually connect you up with technology. We also are a system where our health care is in the air. No, I mean literally, it's in the air. Either you're being medevaced, there's medical travel, back and forth to the main centers, over to jurisdictions. And that has to be considered in how we deliver. It's also high risk as far as those kind of northern, remote, winter-conditioned situations and trying to fly patients and providers around. And so we need to find cost-effective, efficient, and innovative ways of delivering service in the reality of the Northwest Territories. And clearly equitable access is an issue in Canada, but also in the territories. There's a difference between being in Yellowknife or being in Tuktoyaktuk, or being in Fort McPherson, which has 80 people. Not Fort McPherson, sorry, Siksik. The current service delivery in the territories is relatively unchanged since the transfer from Health Canada in 1988, and it's not structured to meet current challenges. So we have introduced things like regional health authorities. We have 8, but a lot of the practice still remains the same. And the land mass is huge, with a small population of just over 43,000 people spread across 30 communities. Aboriginal, First Nation, Inuit, and Métis account for over half the population, and as Terry said, we have 11 official languages. Most of them are very active. This impacts health delivery, health translation of information, prevention materials, etc., and adds to cost. And while we are younger than most parts of Canada, we're also experiencing an aging population, one with a significant incidence of chronic disease, high incidence of social, mental health, and addictions issues, and we face significant disparities in overall health of our population relative to the rest of Canada. So we're challenged by size and population of the various communities. Some have 80, some have over 1,000. Half the population is in Yellowknife. And some communities have no year-round road access. It's mainly fly-in, or we wait for ice bridges and ice roads, ice pilots, ice truckers, that's all from the territories. Significant reliance on medical travel, medevacs, air transport of both providers and patients. Housing and other pressures impact on the retention of providers outside of Yellowknife. High turnover, high cost in moving providers in and out, and a reliance on locum and casual workforce, many of which are end-of-career providers who are coming up for short-term locums. It's generally a nursing model. Primary care centers, health centers are delivered by nursing with providers, physicians rotating into some communities, but not all. We do have a stable pool of GPs in Yellowknife, but again, it's all locums outside, including up in Inuvik, where we have an acute hospital. And the political system is even more challenged. So while politics and policy making is unique in Canada, and as my colleague from Nova Scotia has referenced some of those dynamics, imagine trying to set policy in a consensus government, because that's what we have in the Northwest Territories. There are no political parties, representation for large areas but small populations by MLAs, and it makes them very hands-on. Evidence sometimes is by the N of one, the last person you talk to in your community. They are very involved in individual health care questions. I am called all the time, but MLAs challenge me why somebody wasn't medevaced out. An Aboriginal chief arguing with a nurse saying the person needs medevaced out. And trying to explain evidence in healthcare policy is very difficult in those variety of cultures and communities. So the issue of sustainability in healthcare delivery is significant to all deputy ministers. But in the health, I have to underscore that we have a need for rapid system and policy change and new ways of delivering business. For example, we struggle with bandwidth in an era where everything is about e-health, electronic delivery, diagnostics. We struggle with major power outages where whole communities and health centers can be cut off from any kind of contact for long periods of time. So one of the things we need to do is learn to dance together, deputies, policymakers, and the research community. We do have a need to understand policy making, the disconnect we have, and the levels of influence as we go forward. The process of making public policy and implementation in the public sector is complex and dynamic, and there are several actors, as you know, usually all with different interests. To pursue their beliefs, these groups or organized participants compete with each other, and those with relatively high degree of power can lead the policy discussions, or they can negate any policy being moved forward. It becomes static. And we are different, researchers and policymakers. For example, most deputy ministers I know are action-oriented. They have very short time frames. The life expectancy of a health deputy in Canada is about 24 months, not a lot of time to make decisions. We're concerned with immediate issues on the political issue, and within a 4-year political cycle, we know that the first year they get the decisions made, the real tough ones, sometimes into the second year. Then they throw a bit of let's just maintain it, and the last year you can get some money put in certain areas if you're able to market in the right area. So a 4-year business cycle is about the time frame of the policymakers in Canada. That's not where you're at in the research community, so our sense of time and urgency are very different. There's also tension between us because a researcher needs it to be relevant, need to take the time to do thorough research, and yet as a policymaker, or in this case deputy minister, we need it to be rapid time, right away, ahead of when the policy issue is going to hit us, and with a quick turnaround and ability to understand it. And this is really important in small jurisdictions. So sometimes the constellation of interests around a policy issue predetermine the position the policymakers take and ensure that they are not receptive to new evidence. And that's often missed in the context of the researcher. We need context-specific input to fit our particular policy questions. And the key policy underpinning for key health issues right now is value for money, effective use of resources. Policy and decisions occur at a variety of levels in health system: macro at the large government level or system-wide, meso at the authority or the regional level, and micro at the local institutional provider group or specialty. And when I look at some of the discussions in the next few days and on the presentations you have, I think it's fair to say that we've been able to do a better job at the micro and the meso level, but it's very hard to influence research, have research, evidence, and even health technology hit that macro level. With some examples where we do have the drug agency review that all jurisdictions are now looking to, it's hard to raise it up and have influence at that macro policy level. I think that there is also limited strong evidence about sustainability approaches, the long-term impacts that tend to lead to timely policy making. And we need to consider more the levels for influence when we're doing research and trying to both market and show the evidence. There are barriers at the different levels, and knowledge transfer, an approach that one size fits all, just does not work. You need to know your audience when you're trying to have research, evidence, and HTA influence policy. So in reality, though, policymakers and decision makers do know that research is essential to cost-effective, innovative, and sustainable healthcare systems, and the disconnect is sometimes we just don't get to use it. We recognize the value that research provides in innovation in clinical treatments, the value to us that research provides in the capacity to monitor and evaluate new clinical, administrative, and system approaches as they develop. The issue is how we access it and how timely it is. Results of and recommendations derived from economic evaluation and other forms of health technology assessment are expected to have an important role in policy making and professional practice. But in reality, scientific evidence can be neglected. Complex calculations, arbitrary assumptions, debatable choices of whose perspective to pursue, competing opinions from different provider groups, difficult to understand methods, research design, the underlying philosophy and concepts, and time-consuming processes are claimed as key factors to discourage policymakers. And the real issue, in my mind, is our capacity to take your evidence and use it in a very timely manner to guide long-term policy. We have to, as a group, start to push the evidence in the policy discussions across Canada. And I think there is a role for the large agencies to do that. To do it, we want the evidence to be relevant to the specific policy problems. And I know they are from a researcher's perspective, but you need to really, at a macro level, look at what are the key issues for Canadians and for Canadian public policy makers. Limited resource, equitable access, resource utilization, aging population, value-add economies of any new intervention, just to name a few. You must relate to our realities. Rural and remote Canada cannot be ignored while we have an urbanization, nor can the economics of health be ignored. A lot of our policy and public decisions are made around those issues, societal issues that probably have little to do with actual health delivery. And you have to understand the capacity of small systems to access and use research. My world from Alberta to the NWT is very different. We don't have people in the delivery side or in the government that can actually analyze the research and use it in real-time way. We have to rely on national agencies and we have to rely on southern jurisdictions, but we have to ask you to put a northern lens on it to make it viable to us. So the input of evidence must be timely and reliable so we can use it to really have influence in policy discussions and negotiations. And please, Make it concise. I don't have time to read it. It has to be easily translated. One page works very nicely, thank you. I love summaries and mythbusters. They work. I can also get them at a political level. They can understand those. And that's the key, is being able to translate it to the real decision makers. So we really ask that HTA producers, the researchers, the organizations, the national bodies understand policymaking and its conditions at the 3 levels and decide where you think you can have the greatest influence. We have done great work at the 2 lower levels I talked about. You need to think about societal change and helping to increase the use of evidence in healthcare policy, and you need to understand the real question being formed by the policymaker and provide evidence for that question and for the decision-making process, timed again when it's really needed. So some of the issues in the north, if you're looking for research areas or evidence areas to look at, there are definitely northern delivery challenges. When you are running 1 and 2 nurse health centers in very remote locations, we have to rely on electronic health, we have to rely on digital processing and on technology, but in a northern context where we struggle with bandwidth, where we struggle with power, we do need to have that remote lens. We need to look at evidence around how do we best support our providers. And some of the things we're looking at is what we're calling a territorial support network, to be able to link providers, physicians, nurse practitioners, specialists to those remote communities to help them in the decision making and probably expand their scope of practice. Clearly, there are Aboriginal health issues in this country that we have struggled with, and we need much greater research and evidence there. And access, how we actually provide access when you live in a world that most of it is flown out and flown back. There are great challenges in Canada on health system delivery, and there's great challenges in the north. And I really invite you as researchers to pay attention to us. Thank you.
Thank you, Patty. Message very well delivered. Our final speaker is the Deputy Minister of Ontario, Ministry of Health and Long-Term Care. Prior to this, Saad Rafi has played roles as Deputy Minister of Energy and Infrastructure, as Deputy Minister of Transportation and Community Safety. He's a long public service record, but also worked in the private sector with Deloitte. Please welcome Saad Rafi.